This is who you will be hearing from today. And in 1 second, I'm going to hand you over to Shane, who is my illustrious colleague. And in addition to which, he is a trustee at Mosaic Clubhouse in Lambeth, which is a community care provider that supports people living with long-term poor mental health. Jane Padmore, who is Chief Executive of Sussex Partnership NHS Foundation Trust, and Andy Bell, Chief Executive of the Centre for Mental Health, who leads their work towards equality, social justice and mental health for all. We're all so fortunate to have them with us today, and I want to thank them in advance for doing it, and of course we'll thank them again at the end. Without further ado, I will hand over now to Shane, who will talk to us for 5 minutes.
Oh, and hopefully less, Ariane. So thanks everybody for joining us. Amazing to see so many people here. As Ariane said, I'm Shane, part of the team at Kaleidoscope, and I have the privilege of leading our OD and leadership development practice. I guess there's two reasons we felt really strongly about having a conversation about leadership and mental health. One is that we're really lucky to have the opportunity to partner with so many amazing organisations and providers of mental health services right across the country. Now, this is titled To the Moon and Back. I'm not sure which of these lovely places can be described as moon-like. You can make your own determination. But we're really privileged over the last couple of years to be working with colleagues in this place, including Andy and his amazing team at the Centre for Mental Health, and including Jane and her amazing team at Sussex Partnership. We're sort of fascinated by this idea of leadership in mental health, and this question about, well, is it different or is it the same? Now, I think if I looked at that voting correctly, and no pressure on Andy and Jane to make the case for difference, but probably it is a bit different, has it by a nose. Now, I have my own perspective on that, being a very proud trustee of a community mental health care provider in South East London. I also have a view on that because I'm a long-term user of mental health and care services, both acute and community. So before we go too much further, to all of you and all of your colleagues who do lead in and provide mental health care services, we just want to say a genuine thank you for everything that you do, particularly in the face of, real complexity and a lot of uncertainty. And we'll talk a little bit more about the very real challenges, including parity of esteem in both legislation and funding that comes with leading in this territory. So thank you very much, and thank you to all of these lovely organisations for allowing us to hang around. So just before then, I hand over to Jane and Andy. I just thought somebody pointed out it'd be useful to know when we talk about leadership, what are we actually referring to? So just pop on to the next slide, please, Naheem. Thank you very much. So basically, our perspective on leadership, very simply, or very complexly, you decide. So we're talking about leadership in 4 spaces. So leading yourself. So our view is leadership is an inside-out task. It is very hard to lead others if you don't have the ability to understand and attend to what's happening for yourself, and to take responsibility for how you turn up in the teams and organisations and systems you lead in. And then the other 3 spaces that we're leading for teams, we're leading for the organisations that we work in, and for the systems in which we are part. So 4 spaces. And then there's 3 tasks in any of those spaces, which is to bring people together. So the idea is we're very clear that this is all relational, to bring people together, to set direction, to nurture alignment, and to maintain commitment. So 4 spaces: self, team, organisation, system, and 3 tasks: setting direction, nurturing alignment, and maintaining commitment. So without further ado, I'm going to hand over to Jane, who's going to tell us her story of me, we, and now. Jane.
Hi, everyone. I'm Jane Padmore, as I said, and I'm the Chief Executive of Sussex Partnership NHS Foundation Trust. It's an absolute honour to be here today. I am, first and foremost, a mental health nurse. And I say that because it is very much part of my identity and who I am, and my experiences as a nurse were formative. And I believe my journey to Chief Executive would not have been possible if it hadn't been for the experiences and opportunities I've been given throughout my career. When I was asked to speak today, I spent some time thinking about what to say, and I was reminded how recently, when I was on a weekend away, I was asked the usual question, what do you do? My immediate response was, I'm a mental health nurse. It didn't even occur to me to say that I'm a chief executive, which, having been a chief executive for 2.5 years, I found that quite curious. And I think it didn't ever occur to me to give up my nurse registration when I became a chief executive, and I've recently revalidated. And being a nurse is very much part of my identity, because the philosophy of nursing and my experience as a nurse informs everything I do. And I believe that I won't go far wrong as a chief executive if I abide by my code of conduct and I'm held account to my code of conduct. So my journey is from a volunteer in the NHS at 16, then doing really badly in my O-levels and A-levels. I can't even begin to tell you how badly I did. In fact, I would not be accepted onto nurse training now if I'd done what I'd done back then, and to becoming a nurse and onto being a chief executive. If I start at the beginning, at the age of 18, having received my dreadful A-level results, I didn't know what to do. My mum was speaking to someone on the phone who looked down at the waste paper basket and saw an advert for a healthcare assistant in the bin for people who had just been moved from the long-term asylums out into the community, and said, oh, you'd be really good at that. So I went and applied for it, got the job and got it. And that simple act of kindness changed my life. It changed the course of my life and introduced me to a world of nursing and mental health and learning disability that I had never had before. I was wrongly told that there was no future in learning disability nursing, so I went into mental health nursing. I don't regret it, but I do wonder what would happen if I became a learning disability nurse. But I am aware that I had no concept of mental health or learning disability or learning disability whilst I was at school, or any concept. But I also think that when I started my training 33 years ago, I had no idea of the breadth and the diversity of roles that were available to me in the NHS. Working with people with a mental health problem or a learning disability is an extraordinary privilege. I still remember the names and faces of patients who have made themselves vulnerable to me, sharing details of their life with me, a stranger, who they've just met in their home or on the wards or in ED, and making themselves most vulnerable in the most extraordinary way. We've taken away their liberty. We've been with them when they've been scared, we've been with them when they've been sad, and we're there on their recovery journey. What we do and how we do matters. And that is fundamentally why I've progressed in my career, because at each stage, from being a healthcare assistant right the way up to being a chief executive, I've wanted to make a difference and I've wanted to influence the next level. And I felt that my frustrations at not being able to influence in the way that I wanted to pushed me to the next level. Patients have taught me so much about myself and have also been part of forming who I am as a nurse and as a person. And these experiences have taken me down this path to chief executive, but also inform how I function as a chief executive and how I lead the organisation. For example, as an executive team, every weekly meeting, we start with an overview of every single serious incident that's happened in the organisation, and we name the individuals involved. We learn a bit about them, because that reminds us of the decisions we're making and why we're making them. If we're making a finance decision, if we're making a quality decision, if we're making an estates decision, a workforce decision, a performance decision, ultimately it's because of the patients we serve, and it makes a difference, and it makes a difference every day. And if we're not indirectly or directly improving quality, that's safety, effectiveness and experience and the outcomes for the people, then why are we prioritising it? Although I've had a rich experience of working clinically, managerially, leadership and academically, preparing me for this role. I think it's really important that I acknowledge that my journey has been peppered with people championing me. I was a band 7 nurse and I was supported to go for an 8D that I thought I had no likelihood of ever getting, but they said that no nurse has got a master's and you're the first one that could apply for it, so please apply for it. And I got it. And I've been reflecting over the years. I had a wonderful woman who was a Black Caribbean nurse who was my reverse mentor when I was chief nurse. And we looked at our careers. And over the years, me as a white, middle class, well-spoken, educated woman had a very different experience to her, despite us having similar trajectories within the nursing career and similar opportunities. The difference was I had people championing me and people standing up for me and saying, why don't you? You can do this. And I think it's on all of us to strive to be champions for others as leaders in mental health. I've worked in the NHS since 1990, and throughout that time I've heard people say we're in a cycle. There's a never-ending cycle in the NHS. We're always changing. It doesn't feel any different. My view is, and I don't know whether it's because I'm not in clinical services now, the scale of change that is needed at the moment is huge and the scale of the task feels very different. And I think it's going to take bravery and it's going to take a forensic focus on detail, compassion and accountability and remembering the population we serve. And I think balancing the national strategic pressures with the local integration pressures, with the organisational pressures, where I'm the accountable officer and ultimately if something goes wrong, it's on my head, is a balance that is quite frightening, if I'm honest, and makes me feel very anxious as a chief executive. But I do know that if I'm balancing all of those tensions, actually, I can't go far wrong. If I'm holding in mind the organisation and I'm clinically leading it, quality assuring it, operationally managing it, and it's financially sustainable, we will be improving quality for the population and we will be working in an integrated way. Looking to the future, I think the Darzi report is a significant marker in time. The government narrative that the NHS is broken is hard to hear, particularly when you've worked in the NHS as long as you have. But if I'm honest, hand on heart, I think it's pretty accurate. And I think the Darzi report is pretty accurate. And I have to say, I'm really impressed by the amount mental health is peppered throughout the report. I think it would be remiss if I said I wasn't a little bit disappointing of the positioning of learning disability. It mentions learning disability nursing and mortality rates, but not the wider learning disability challenges we face. I am delighted with what it said about neurodiversity, because I think that's something that does need a light shine on it. It's an elephant in the room that in mental health circles we're talking about all the time, but actually we haven't got a grip of yet. So it's been in the too hard to tackle category. So bringing it into the light is important. I am hopeful, but I have a touch of scepticism that always comes with new strategies and plans, politics and general weariness. But hopeful because I think we've got some brilliant leaders and brilliant clinicians. We've got a brilliant population who are really want the NHS to succeed. I also think we've got a Secretary of State who wants to be the Secretary of State and who actually cares passionately about the NHS. And I think, you know, over the time I've been chief executive, I haven't met a single Secretary of State. I've now Wes Streeting has come to speak to us personally twice, so it feels a very different flavour. Whether I believe in all his policies and agree with all his policies, it does feel different. And I think it's on us all now to engage in the 10-year plan. We've got the Darzi report, that's the diagnosis. The 10-year plan is now the diagnosis, and we as leaders have to stand up and contribute that so that we make a difference for the NHS.
Thank you so much, Jane, and over to Andy. Yeah.
Thanks very much. Thanks for having me. Nice to be here, and great to spend time with colleagues and friends, and to reconnect with Kaleidoscope. What a brilliant organisation you are, and at Centre for Mental Health, we've had opportunities to work alongside you on a number of different projects over the years, and it's always an absolute pleasure. So thank you for the work you do. You're a fantastic organisation and brilliant partners. So I work at Centre for Mental Health. When Jane says, what do you do? Well, I work for a mental health charity, and it's one that I've been at for some time. So you don't need to know much about that. But I guess what I think leads a lot of people, particularly in the voluntary sector, into working in mental health and then kind of taking up leadership positions of whatever sort, is a sense actually this is a social justice and equity issue. It's more than a clinical issue. It's more than a health and medical issue. It's about so much. And I think all of us who work in the mental health sector see that mental health is in many different places at the same time. We know that we are part of health policy, but often a marginalised part of health policy. And if we think we've won parity of esteem, then we're kidding ourselves. We haven't. We get little moments of parity of esteem and then we get knocked back again. And as soon as you take it for granted, it goes away. So we know how important it is to keep fighting for that. And I do use the term fighting quite deliberately. We have to scrap for it, actually. But we also see that mental health is involved in discussions around the benefits system, around education and schooling, the lives of children. We've just seen the Good Childhood report a couple of weeks ago saying how mentally unhealthy childhood in the UK is for children growing up. So there's an enormous amount of places, not least the criminal justice system, where mental health is a hugely important part of those discussions. And as people who call ourselves leaders, whatever that means, in mental health, we've got to be part of all those discussions too. We can't just sit in our own little box. And that's the great thing. We can make a huge difference. And over the years at Centre for Mental Health, we've done everything we can to bring good quality evidence, the best available evidence to bear on all of those debates, whether it's within the NHS, and scrapping for a fair share of resource and attention, whether it's in the wider world and whether it's with governments of all the different persuasions we've had, then we will always be here to make the case for that. In terms of what we're wrestling with now, my goodness, that's a long list. I can't believe you asked me for that question, but let's talk about some of those things. And fundamentally, we are, with a new government, we want mental health to be a priority for the government. We believe it's a whole government issue. There is so much that government can do across all departments, all executive agencies, across all of those different places to promote good mental health and well-being, and to ensure that people living with a mental illness have a fair chance in life. At the moment, those chances are not taken. Government isn't doing what it can to promote the nation's mental health, and it's allowing people with mental illness to be treated in very, very harmful and discriminatory ways. We've got a new government, so let's give them a chance to do better. But we know that at present, things are not as they should be. We also, of course, have to make mental health a priority within the NHS. And that means both nationally with that 10-year plan. We want a fair share of attention, and a very interesting comment in Darcy's review that we need to lock in a fairer share of resources for mental health services. The Mental Health Investment Standard's done a fabulous job in holding us steady, but it hasn't shifted the dial on the proportion of resource that go into mental health services, just hasn't. And of course, that's why we need to be working at every single level of the system, whether that's within the health boards in Wales and Scotland, or whether it's within the integrated care boards and partnerships and whatever's in England. It's really important that for us that we're part of those conversations. We know that it is important also to be challenging established ideas about mental health and mental illness. We need investment in mental health services, but we don't need more of the same. We need actually to change what is offered. We know that the current offer doesn't work for many groups of people. And we hear time and again that groups of people with the poorest mental health get the least access to good mental health services and the poorest experiences and, unsurprisingly, outcomes. So we can't just keep doing more of the same. That's really important. And we do have to tackle the entrenched power imbalances, don't we? There are many unheard voices. There are many unseen people, or people whose needs get ignored and not taken seriously. So we really need to think about that. There are many, I think, leaders now who don't sit in kind of traditional leadership roles with big fancy sounding job titles, but they're leaders because they are prepared to challenge the status quo and what is seen as normal and normative, and bring a different way of thinking about mental health and well-being, and we need to nurture that. So in terms of where we're going, where next? Well, that's a fun discussion, isn't it? I mean, I think fundamentally what we're seeing is that mental health leadership needs to go beyond that kind of rather old-fashioned idea of heroic leadership, usually male, the person with the big fancy-sounding job who makes everyone's problems go away and is in charge of everything. That's not what leadership's about anymore. It's not about hierarchy and management, or it shouldn't be. Management's terribly, terribly important. And we're all bored of hearing about managers in the NHS being bashed for a political point scoring. But leadership and management are different to each other. And I think with leadership, it's about learning humility, being able to listen as much as you talk, probably about twice as much, and being prepared to co-produce ideas and work in that very, very different way. We know about the importance of compassionate leadership. We hear it endlessly. We talk about it endlessly. But we know from people's experiences of working in the NHS that it's not always practiced and it's not always what really happens. And then I think crucially, we need leaders who understand the structural nature of mental health. Mental health isn't about us as individuals with either good or poor mental health for some kind of quality within us. It's about poverty. It's about racism and racial discrimination and other forms of discrimination. It's about gender inequality. It's about all the things we know drive poor mental health and the unequal nature of poor mental health. So we need leaders who are prepared to build services that are anti-oppressive. The patient and carer race equality framework sets a really good starting point. And of course, we need to replicate that thinking across other dimensions of inequality, which all wrap up in each other. We need to look at why mental health services are so poor at meeting the needs of specific groups of people. Those who are autistic, for example, those who are homeless, those living in rural areas, people with long-term conditions. There's a long list of people who get a poorer experience. We need mental health service leaders who understand the importance of holistic support. We need to understand why it is that people with a mental illness lose their lives 15 to 20 years sooner than average, and the fact that that is linked again to poverty and discrimination against people with a mental illness. And the importance of meeting people's basic needs first. And then I think there's a really interesting quality about how our leaders are a voice for mental health that's prepared to stand up and be heard and be counted, but also to have that system leadership style of working in partnership, working alongside others, not thinking you have to be in charge all the time. And having those soft skills, a fascinating balance, and massive respect to people like Jane who run mental health services locally and the enormous challenges you face every single day. Thank goodness we have people like you.
Thank you so much, Andy, and again, thank you to Jane. This bring us back to this slide where we asked people what they want to get out of today. And just to remind everybody that when we put it to the vote earlier, the one that got the most votes was innovation and system change. So over to you, Shane.
So, Andy, Jane, thank you very much. So just two questions. I'm going to ask Jane if you could just take the first one, because it's a build. Then Andy, I'd like to come back to you the second one. So Jane, the first one is I noticed in myself, so I'm just paying attention to myself when you've both spoken. I noticed an anxiety about Christ, the challenges of leading in this space. I'm not sure I would have certainly the skills or the fortitude. I'm really interested, Jane, from you about what allows you to hold all that. How do you develop your practice? What are the sort of the real fundamental things that you think you see are making a difference in good mental health leadership? And then Andy, I'd like to come to you then about this narrative about everything being broken, because part of your work is shining a light on things that aren't working, but also shining a light on where things are good. And I'd like to just hear a little bit from you about the research that you've done about some good practice. So Jane, how bloody hell do you do it?
So I know this is going to sound a bit trite, but I have a fabulous team, and I I'm very purposeful in saying that. I have a very diverse team, as you know, Shane, who are, I think I've almost got almost every protected characteristic on my exec team, but it's like herding cats. But I have an incredibly strong leadership team, and I think one of the things I did in my first year of being a chief executive was to recruit a whole new executive team and invest in their development, both as individuals and as a team. So I couldn't do it without them, and I don't just say that as sort of just to praise them. It is absolutely true. I think the other thing is, I do think that you said at the beginning about working on yourself, and I do really value my coaching and understanding my own way of being, and my own strengths, and not being too hard on myself, and having a great husband who supports me in the background so I can come home and I don't need to carry everything. I can be myself at home as I can at work. And the third thing I'd say is, I become really, really stressed if I'm not authentically me. I need to absolutely be me at work. So what you see is what you get. I will cry sometimes. I will get really stroppy. I will get frustrated. I will tell people what I'm feeling about things and own what I'm feeling. And for me, that isn't about my leadership style. That keeps me sane and that keeps me in the space. But I think being in mental health, I'm more able to do that. And just give one example. I was at a meeting the other day that actually Shane was facilitating, and I was reflecting to the group, as a mental health nurse, when there's a lot of rubbish going on around me, I've learned to stay very calm and to contain my feelings and then deal with them. Whereas in the acute sector, there's a sense of, you have to show that you really mean business and you're really, really responding to things. Whereas I can look sometimes like I don't care because I'm just not responding, and I'm processing it and remaining calm to try and remain calm outside of it. So I think knowing myself and being authentic is really important. Not sure I've answered you properly, Shane, but that's a ramble.
No, it's not a ramble at all. And it'd be good to come back to this, because actually what you've talked about is not carrying it all, either inside yourself or in your professional life. And of course, what we know is, for a lot of people, myself, one of the sources of poor mental health is you feel they're just holding on to or being asked to carry just too much, and that sharing and being seen and being supported, and also being able to be your true self and not pretend. And I think there's an interesting metaphor there for what we're talking about. Andy, so a little antidote to the broken, or a little bit of tough-minded optimism. So maybe a broken but. Where can we look for inspiration and encouragement?
Thanks. Great question. And this thing about being broken, there's an implication of broken as irreparable, isn't there? And I think that's the unhelpful nature of it. And I was stunned by some of the language in the report about mental health services. They rightly talked about the unacceptable state of the buildings and facilities that mental health services have to work in and people have to spend time in as inpatients. But some of the language was deeply stigmatizing, and I do think that's problematic. I think realistically, we also have to accept that the NHS, and particularly the part of the NHS that we connect with, is it really sometimes very, very stuck for very important reasons. The fact that we still have about half of our spend going on bed-based services that generally people don't want to be in. And generally are kind of experienced very negatively. And yet most support is provided in the community, and most people want their support in the community, but it's very, very hard to get off the kind of crisis management that we're in, and that kind of day-to-day dealing with the difficult, and the fact that the NHS has been at the wrong end of 10 to 15 years of austerity policy that have gutted local authorities and the things that keep people well. So I'm going to come to the positives, Shane. I know you asked for positives, but we kind of have to accept the negatives, don't we? And so, we can talk about how we want to shift to something better until, the end of the day, but it's very hard when you're constantly in crisis management mode. I think in terms of things that make us feel hopeful, well, first of all, go and have a look at any healthcare system abroad, and particularly in the States, and celebrate the National Health Service and the achievement that is a healthcare system tax funded, free at the point of use. And for mental health services in particular, that is so important. It is so precious. And we've got within that a workforce, both in the NHS and in the voluntary sector and in local government, that really cares, that really wants to do a good job, and really believes that actually we can do better. And I think we see that in many examples of services that are doing things differently. We work alongside a lot of the youth hubs that are providing support to young people who don't necessarily want a formal referral to a mental health service, but want some help with their mental health. We see great examples of, for example, providing housing support in mental health services, including in Jane's own trust, and really thinking about people's housing rights, basic stuff, thinking about the importance of supporting people with employment. We've gone from there being one individual placement and support employment service in a corner of London to it being the standard issue across the whole of the NHS for mental health services. We haven't finished, got a long way to go, but every day we're training people at the centre in IPS skills, and we're creating a really exciting workforce of employment specialists. So we can change, we can make things better. It's not broken, but we've got to stop digging ourselves out of this hole we got into.
That's lovely, Andy. It's really interesting. The IPS is an interesting starting point because it starts from the position of not risk but potential. And I think there is something interesting in our narrative about how do we get the right balance between risk and potential. So if we talk about cancer, the idea that someone's a risk, of course, it's not there. But so much of our language and our policy making and our funding, I think, is thinking about risk and not about potential. Now, I do want to call into the room, I think it would be wrong not to, Nottingham, and the tragedy that played out there. And of course, one of the shifts that West Streeting here in England has said is he wants to move care out of the acute sector and into community. And I know that Claire Murdoch has written to all chief execs about this, and Jane, you know where I'm coming to you on this. I just want to get a sense from you both about where we're at on that shift in the shadow of Nottingham. Jane.
Thank you. So I think the first thing I want to say is that obviously this is a very tragic situation, and it happened in Nottingham, but it could happen anywhere. And I think if we become complacent then and think, well, it couldn't happen where we are, then we're on really dangerous ground. I think the shift to the community is helpful in some ways, but I worry that it sort of almost makes hospital bad and community good. And I don't think it is. It's appropriate use. That is a bit like restrictive practice. The appropriate use of restrictive practice, the appropriate use of beds is what we need, and we need flow and we need the focus. I suppose one of the things I was really struck by when I was thinking about what could happen in our trust, that could create the perfect storm that happened in our trust. I'm less worried about assertive outreach. I'm more worried about our assessment treatment teams who have large caseloads with locum doctors who don't know the patients very well. So the high turnover of staff who don't have the relationship with people with severe mental illness. So our assertive outreach teams tend to have good relationships and know those patients well, those people well, and will follow them up. but those that are on the long, that have severe mental illness, but maybe have been stable for a while and have moved to assessment and treatment teams, and you've got locums coming in and they don't know the warning signs, that's the bit I'm more worried about. So I'd like to see the focus move a little bit more away from assertive outreach to severe mental illness more generally, and how we look after those with long-term mental illness in a way that is least restrictive but most appropriate to their needs and personalised.
Thank you, Jane. Sorry to put you on the spot. It's such a big issue to unpack, but I just thought it would be a remiss not to mention it, given the shifts conversation. Now, just want to come back to this idea of people are really interested in innovation and system change. And both of you sort of talked about mental health having so many touch points and interfaces in a way that, of course, doesn't play out for some other health conditions. So, in terms of leadership sort of skills, Andy, you've talked about needing to be sort of scrappy and pushy. So it'd be interesting to hear a little bit more from you about that. But generally, what does it take to just start from a position of this is systemic, and therefore I have to think about how to design care in different ways? What are the core skills or behaviours or values that leaders need to have? Andy, I'll start with you.
Gosh, that's a tricky one. And again, working for a national charity, our kind of set of things we have to deal with is very, very different if you're working in a trust or a place-based service where you've got very, very different challenges. I think what we would observe is that we have to keep making the case for the importance of the public's mental health and the importance of fair treatment of people with a mental illness. We shouldn't have to. I'd rather we didn't, but we do. And so that ability to build those arguments, we sometimes talk about the costs of not doing so, and the economic and social cost of mental illness is now 300 billion a year, which is twice the cost of the NHS. So we've got those economic arguments, but we also don't want to commodify people with a mental illness, or treat people as somehow kind of pawns in the wider economy. That's not a rights-based approach, and we can do better than that. I think it is, though, about ensuring that we're really able to kind of go out there and have those conversations in different places. It always helps to actually kind of work alongside experts by experience. And I don't mean doing the old-fashioned thing that you used to get at conferences and events or meetings of having one person to come along and be the case study, the person who's has to tell their story and then gets talked about. We need to do better and different than that. It's about co-producing knowledge and understanding. We've been lucky to work with some parts of Greater Manchester in particular recently, and some other areas where we've been looking at complex system mapping, understanding what it is that affects the mental health of the population and the lives of people with mental illness, by bringing together partners as equals to think about what they can do to support better mental health and what better mental health would mean for them and how they can support one another. And I think that's a different kind of leadership, because it is genuinely about people bringing people together to find common ground, to be generous towards one another, rather than this traditional thing where public services seek to shift costs over to one another and to avoid blame for things that are difficult. Actually looking at where they can come together with a real shared understanding and a common purpose. And I think that's a really exciting development, and it's something we're really keen to do more of, and would love to do with anyone who's on this call today who's interested in that.
Andy, just a little build on the question about thinking systems. I'm interested in financial flows. Sorry, that's really dull and technical, but let's talk about what this is. It's about power, and it is about resources in a real way, resources that follow. So you're sitting there holding your, what SPF does, it cuts across lots of boundaries. But what are the conversations you're having with your ICB, your systems partners, which is giving you optimism, or where do you think we're still a little bit stuck, where maybe we need to be doing something different to release or unblock new flows and new models of care?
So that so my optimism comes from the doing. And I think that's fundamental. So we've come from a system of competitive markets in the NHS now to being in integration. That takes a whole cultural shift. It takes chief execs working differently with each other. It takes being open about your finances and open about your challenges with each other. And it means about an honesty that can make you feel very vulnerable. Certainly when I have brought some of my analysis of what's happening in my trust that is not so positive to all the system leaders, it has felt very uncomfortable as the accountable officer and the chief executive, but it was the right thing to do. But I think unless we are honest about where the challenges are, we can't move on. We can't move on, because we're not building, the acute trusts have all this pressure around elective care about EDs. They don't know about my CTOs or people on Section 135 in the community. They're just worried about the people in CTO, in their ED department. How can I imagine? I have no idea what it's like to be an ED and have a road traffic accident coming in. They have no idea what it's like holding the risk of people on community treatment orders needing to be recalled to hospital in the community. So I think the thing that gives me hope is the relationships we're starting to build, chief execs to chief execs, chief medical officers to chief medical officers, and that going through the organisation at every level, where we're starting to be open and transparent about our challenges, but also about our successes, and the ability to think, well, we might need some money with this, because then it will take pressure off on you, rather than just fighting for it. Well, it's not fair. We don't get enough money in mental health. We only get half of what we have in comparison to everybody else. Not fair is never going to win an argument in the NHS. Not fair is not going to cause action. Action is. And so by actually engaging and demonstrating the outcome when you get more money, then you get the trust and relationships are built.
Have we lost Shane?
He froze then, I think.
Yeah, no, I'm just back. I think I was just getting too emotional. My laptop was sort of breaking down. I think this idea. I know Sarah Morgan's on here from the North Sutton on ICB. I know Sarah's been really interesting, certainly to me, about thinking about what it means to be system leadership, and this idea of curiosity and caring beyond your personal and professional boundaries. And I think there is something very particular about it's the mind body sort of disconnect. It is almost an entirely different world and a different practice. So last question for me for you both. We've talked a little bit about the three shifts, and one of the big shifts community to out of acute and into community, and the other two are analog to digital, and from prevention, or from sickness to prevention. So how do those two things just sit with you as meaningful levers to address some of the challenges that we've talked about here today? So you can talk about both. You can talk about one, so analog to digital, and prevention to sickness to prevention. I'm thinking about that in, let's say, a 10-year electoral cycle and a 1-week media cycle.
Shall I go first then? So they resonate quite well with me, but the devil's in the detail for me. So I'm going to be honest, I'm a little bit sick of the prevention talk because it's all ends up with talking therapies and the SMI gets forgotten. So I think we need to be really clear. We're talking about secondary prevention as well as the health promotion and the very lighter end of it. And then I think we could make a difference if we're thinking about prevention in its entirety and its different definitions, not just in the either you're treated or you're prevented.
I love that. There's something about the specificity of language. So coming back to your point, Andy, about needing to be advocates and campaigners, I think that's really, really interesting. Where we're going to get where's most risk, where we're getting most benefit is secondary prevention. Thanks for calling that out, Jane. That's lovely. I'm going to take that away. That's really interesting for my work as a trustee at Mosaic. Andy, what are those two other shifts? What are you feeling about those?
I mean, inevitably, the three shifts are actually kind of interconnected, aren't they? So if we are going to move more support to the community, we're going to need better ways of preventing distress and preventing people who are living with mental illness becoming so unwell that they need emergency care. And the role of digital has a part to play in both improving the support people get when they're unwell and potentially supporting people at that point before they become diagnosably unwell, but nonetheless are experiencing significant risk to their mental health. So with digital, there's clearly promise. There's some exciting opportunities to meet people, particularly younger age groups, but not only. In digital forms of mental health support. Some of it's getting very sophisticated and very good, but there are equity and safety considerations that have to be really thought about here. And I think the conclusion we've come to is it has to be part of the mix, but you don't either assume a certain group of people or a certain type of need can be met only by digital or only by face-to-face. You need a mixed economy. There's tons of things we can do to prevent mental illness. The first thing is to tackle poverty. We often get wrapped up in this idea of prevention has to be an initiative, or indeed it ends up being a form of treatment. Talking therapy isn't prevention, it's treatment. But if you tackle poverty, if you tackle the housing crisis, renters reform that's coming through Parliament, if you have local public health teams that are assessing and understanding the needs of their communities, a really good mental health needs assessment is fundamental. If you've got that, and you've done it properly and you've done it in an engaging way and you've had your mental health services provider involved in the conversation, not marginalised them, we can get rid of this ridiculous division between treatment and prevention and actually see they're two sides of the same coin. Preventing a crisis is really important, but so is giving parenting programs, helping young parents to support their kids better with positive parenting techniques, which we know protect mental health. Working with minoritized communities to promote mental health and well-being and tackle the disproportionate use of school exclusions, for example. We know what harm school exclusion does to mental health, particularly for children from some racialized communities, and yet it's happening more and more. So if we think about prevention in its broadest sense, there's a ton of things we can and should be doing. We need national government to take the lead, but while we're waiting, there is something that can happen in every system, every local authority, every health and wellbeing board. They can make so much progress just by taking this a bit more seriously.
Oh, thank you, Andy. I just love that. Just thinking about what we really mean by a system, and I think sometimes we can get stuck, can't we, on the health and care system? So we're talking about something much, 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 much broader. Last just thing for both. So Jane, you've met Wes three times, and let's assume he's going to be back for twice, right? Well, let's say third time's the charm. And Andy, you get a second to think about this. So you asked him to, one small, immediate, meaningful, practical thing that we might be able to do to just allow a new possibility to emerge. What would be at the top of your practical wish list?
I don't mind saying what I actually said to him, which was I would like cross-departmental working and conversation. So I talked about the Ministry of Justice and the Department of Education and social care and health. We all need to be talking together because we're not going to get any of these solutions on our own.
Are you able to tell what sort of shade of white Wes went?
No, he said that is absolutely what he's doing, and he talked about the prevalence of neurodiversity in the offender population and the importance of housing. So he did actually respond positively to that.
Very encouraging. Andy, you, and then
that's great.
Going to bring us home.
So one thing government could do that's virtually free but would make a massive difference is have a mental health policy test. So whenever a government decision is made in any department, they just have a look and ask the question, what will this mean for the public's mental health? What will this mean for people living with mental illness? Can we make this policy better? How can we have a net positive impact from as many policies as possible on people's mental health and well-being? It's virtually cost-free. It make a massive difference. We think it would be helped to be backed up by a mental health commissioner equivalent to the Children's Commissioner. We've published papers on both of those things. Please do take a look. And these can be replicated locally too. There's nothing to stop a local authority saying, let's have a mental health policy test here. Even an integrated care board, maybe.
Wonderful. Thank you both so much. Ariadne.
Thank you again, both so much. It's just the last 2 seconds from me, just to really quickly say thank you to everybody for joining us, and to let you know about the next event that we're doing, which is actually in person on the 10th of October. So if you're in London, it would be wonderful you could come, sort of looking at the other side of this question. What is the impact of being a leader on an individual's mental health? We have some great speakers joining us for that, including Matthew Trainer and Kelly McGovern. And if you could take 1 second, please, to fill out our evaluation form. I have just put it in the chat. We really appreciate it. We are always trying to make these better, and we'd love to hear what you have to say. And the recording of this will be sent out. And also Andy has written a very nice blog about the Darzi report, so I'll include that with the recording and the follow-up. And please do get in touch. Last slide, please, Naheem. These are all the ways that you can reach us. Do reach out for a conversation or a coffee, and thank you so much. Look forward to seeing you again at a future event.